Thank you everyone for joining us. And again, I do apologize for the technical difficulties. Unfortunately, the web service that we were relying on had a bit of an issue. My name is Carrie Melchiski. I am with the Parent Information Center of Delaware, and we are thrilled to partner with TheraPlay for this series of webinars. Today's session is Helping Children Who Won't, Can't, or Don't Eat, and we are being presented to by Melissa, and I apologize, Melissa, I'm not going to try to mispronounce your last name.
That's okay.
So, right. Melissa, if you want to go ahead and take us away.
All right, I will do my best to present as much to you guys as I can within a short time frame, but I'll be covering feeding difficulties that we see in kids and how we address them. Okay, so many of the families that come in for therapy and for evaluations ask us, why isn't my children eating? Sometimes it's clear, sometimes it's not so clear. There are some different things that we might suspect. One of them being delays in their abilities or their skills. It could be an oral motor concern where they have difficulty using their tongue and jaw movements to move food around in their mouth and chew and swallow. They could also have poor oral motor strength that impacts their feeding skills. As an OT, I often see kids who have poor fine motor skills, and that's impacting their feeding abilities. This could be something like bringing their hands to midline to hold a bottle when they're bottle feeding, being able to pick up a piece of food, grasping utensils and bringing food to their mouth successfully are just some examples of that. We also have motivation issues that impact these kids. So if these kids have underlying issues like reflux, allergies, a lack of appetite, they're obviously not going to be motivated to eat because it's not a pleasant experience for them. And then lastly, we like to think about the child's environment. Are there some issues popping up there? Are parents really struggling with dealing with mealtime behaviors, and we need to provide some education and training? Is there faulty knowledge about progression of stages of food? Positioning during feeding is something else to consider. You know, when should they be in the high chair? When should they be seated in a regular chair? What should that positioning look like during feeding? And then two, it's what's the surrounding environment like? Is there a lot of distractions going on? What's the stress level and the atmosphere of the family? These are all things that we have to consider that could be impacting that child. Okay, so there are many, many reasons to refer for a feeding evaluation. There could be some medical things going on where you'll see frequent vomiting, chronic constipation and diarrhea, difficulty advancing to textures, so getting through some of those stages of food, as well as chewing their food. We've had some infants come in for a consult with speech as they have difficulty latching on to the breast for breastfeeding. We see kids that have poor self-feeding skills, mouth stuffing and pocketing food, choking, gagging, retching during meal times, and overall stressful meal times in general. Some other things that might be impacting these kids that might warrant a feeding evaluation: if they're experiencing a lot of congestion, excessive drooling, not mouthing toys or exploring with their mouth. That's a big red flag for me, especially in OT with kids with texture issues. When they were younger, did they put their toys in their mouth? Did they put their fingers in their mouth? These are all things that at one point are age appropriate and that they should be doing in order to tolerate textures. We also like to ask for feeding evaluations, has the child had a swallow study? So if they're having difficulty chewing and swallowing, that's a type of medical test that they may need to have done to clear them for therapy and also to rule out any other concerns. We also like to ask, have they had allergy or reflux testing? So these are crucial things that need to be addressed prior to really starting feeding intervention and being successful. So we always recommend a multidisciplinary evaluation. So That team is far and wide. It's not just occupational therapy or speech therapy, which is what we have at TheraPlay, but you're also going to involve other professionals as part of that child's team. So you're going to be visiting potentially a pediatrician, a GI specialist, nutritionist, a behavioralist. All of these professionals can be part of that child's team. Through those different evaluations, we want to gain their medical history, knowing, have they had reflux, allergies? Have they had the medical testing I mentioned before, and a physical examination? What's going on inside their body? That could be something that we might not be able to pick up on during our evaluations, but a medical professional could test and look for those things. During our evaluations as an OT, I like to do a parent interview. So I'm asking questions about what are their main concerns that they're seeing, getting a background about that child's feeding history. When did they start seeing some of their present difficulties? I like to get a sense of what their mealtime schedule is. What are they frequently eating? What does the environment look like? I'm in an outpatient center, so I don't get to see their everyday natural environment where these difficulties are occurring. So I really rely on that parent interview to gain that information. Within that interview, I like to know more about their developmental skills. Are they meeting their other milestones besides feeding? Is there a fine motor issue? Are there gross motor issues? Is there a speech delay? I also want to know about play. How a child plays tells us a lot about their sensory system. How are they self-regulating? And how is that impacting their feeding? Within the evaluation, I like to do some sort of observation. So I have the parent bring in food for the evaluation, and that includes foods that the child's comfortable and familiar with, so I can see what foods they like. I can also look to see oral motor-wise, how are they chewing and managing foods, because they're likely not going to eat those foods the parent brings that are challenging for them. So again, I like to see a mix of preferred and non-preferred foods, and I sit back and observe. I want to see how the parent and child interacts with each other. I want to see their response to food. How are they presenting the food? What kind of utensils they're using? How are their self-feeding skills? So after that, I work towards identifying caregiver expectations. So we'll talk about I recommend therapy, why it's needed, and establishing goals in a collaborative way. I want to work on foods that are meaningful to that family or for that child. There are so many foods out there that we have to find a point to start. So that's always important. We want to discuss rules and expectations for mealtime and make sure those goals are realistic and that we also keep nutrition in mind. We have to find a good common ground and starting point. Also during the evaluation, we like to look at posture and the child's upper body strength, and this is often through observation. What does their posture look at the table? Are they struggling to sit up tall and have poor trunk control, that they're working so hard to sit up tall that feeding is challenging for them? That's something that I have to consider. Feeding really requires higher level oral motor control and coordination. If the child has difficulty just being able to have the strength to sit at the table, then that's something that we have to address in therapy. So I have a visual up there, and it just shows how everything's connected together. You have to have good pelvic stability to have trunk control to sit at the table, which enables head control, jaw stability, and then tongue control and lip mobility. So everything really is connected. We might even refer some kids to physical therapy if they need additional core strengthening in addition to the feeding therapy. So my background is being an occupational therapist. At TheraPlay, OTs primarily see kids who have sensory-related feeding issues, whereas our speech therapists see kids who have more oral motor issues related to feeding. So I'm going to touch upon some of the speech. So I'm going to talk about oral motor issues with speech therapy. The speech language pathologist is going to look at oral motor areas to figure out areas of weakness and decreased coordination that might impact chewing, swallowing skills. They'll look at labial or lip seal closure and movement. So they'll ask the child to do things like press their lips together, purse their lips, smile, as well as assess their tongue movement. So they'll use a target such as a tongue depressor and have the child protrude, elevate, and move their tongue side to side to see that kind of range of motion and coordination. And with that, observing the presence of tongue tie. I also like to look at the child's non-nutritive chewing skills. So we'll have them chew on something like a chewy tube just to see what their jaw stability looks like and their chewing motion. And then lastly, addressing their oral awareness to taste and texture. So we typically use vibration with that. Use something called the Z-Vibe to see if they tolerate sensory input, as well as a nook brush, which is kind of looks like a small dowel with a texturized tip in order to increase their oral awareness and with their responses to texture. Okay, so see if our video works. It's a therapy session example of a 12-year-old boy coming for feeding, diagnosed with autism, and he's working on lateralizing or moving his food to his molars once it's fallen under his tongue. Okay. So during an oral motor feeding session, the therapist is going to use some sort of warm-up to increase the child's oral motor awareness and awaken their mouth, and then gradually provide whatever taste or texture they're working on to their mouth. They'll address exercises to increase their tongue movements, and then practice that with the challenging foods. So you could see in that video the point where they were practicing those tongue movements with a food that might have given that boy a little bit more difficulty. Something else that they might address within the sessions, if the child presents with a tongue thrust, they're going to work on increasing awareness of proper tongue placement. So that's oral motor speech therapy feeding sessions in a very quick nutshell, but there's so much more to it. If you have concerns with those areas, definitely seek further advice. But I'm going to move on to the OT portion of the presentation for you guys. So I have kids come in for occupational therapy for feeding sessions to address issues with texture. And there are a variety of contributing factors that I have to tease out during the evaluation and treatment. That can include oral motor delays, past history of reflux. They might have issues with taste, texture, or temperature. Some kids might be undersensitive to those types of things where they don't have good awareness when they're eating. But most of the kids I would say I have are overly sensitive to taste, texture, and temperature. Even some kids with smells. I treated a boy a few years ago where he could not sit in the lunchroom with his other friends because he had such a strong gag reflex to the smells and the sights of certain foods. He couldn't sit with his peers. So we worked within therapy, and his parent worked with the school to get him to participate in an appropriate feeding environment. We also want to think, did these kids have significant past traumatic medical experiences, tube feedings, reflux, other GI issues that might have impacted their ability to feed and enjoy mealtime? A lot of the kids I see have a diagnosis of autism. There typically are some sort of feeding issues with kids on the autism spectrum, most often texture-related issues. And then we have to think about kind of society today. Kids want to play, but do they have enough playtime? Schools really stress the academic piece, but kids aren't getting as much functional play. And really, the literature out there shows that play helps reduce stress. And if we can reduce stress, these kids are most likely going to tune into that hunger signal and have a desire to eat. So it's an interesting point to bring up. So with that being said, the kids that I see often have sensory sensitivities and food selectivities. So there's different, just general treatment strategies that I use. I use a graded approach when working with these kids. That starts with tolerating food on the plate and taking little baby steps. The food can be on the table in front of the child, but they're not interacting with it. They blow on it. They touch it to their lips. They kiss, lick it. They touch it to their teeth. They start to make bite marks. Eventually, they hopefully start eating the food. But it's little baby steps, and you might be on one of those baby steps for a few sessions before you get to the next one. Depends on the food. Another strategy that I'll try is doing a ratio of preferred and non-preferred foods and increasing their exposure to that. So I might have a spoon with a type of yogurt that they really like on the front and maybe a texture of a fruit or something on the back that's less preferred, or a different type of yogurt. I might do 90% of that preferred yogurt and only 10% of the non-preferred, and backload that on the spoon so they see the preferred in the front. And then gradually, as they start to accept that non-preferred flavor or texture, I'm going to change the ratio where it's 80-20, 70-30, 50-50, so on and so forth. This helps them kind of gradually get comfortable with that food, and that's really important because we want to keep the child's trust during therapy sessions. Peer modeling is also helpful. So in some of my sessions, if I can do some of the things the kids are doing with their food as well, it's really motivating and encouraging to them. And also I can show good behaviors during mealtime, good manners, and they just have fun with that too if you're trying some of those foods. I allow for play and exploration during our session, so we may play with food by stacking, sorting, making pictures. We have a feeding game. It's a board game called the Castle of Colors that a lot of kids like. I recommend food prep, so making your own little meals with kids, involving them in grocery shopping, and makes food less threatening. Oftentimes I'm doing sensory strategies with these kids too to self-regulate them and engage them in play before they transition to the table to eat. It kind of puts them in a better place. If they are a sensory seeker and seeking a lot of movement and have trouble sitting still for mealtime, well, then I better do some sort of sensory activity before we sit down, or they're not going to be successful to focus on eating. I'll work with the families to provide strategies, including a mealtime schedule. Some kids are, pickers and grazers, so we have to find a way to limit that so they'll engage in mealtime more. Also to limit the intake of their fluids if they're drinking too much and then they're not hungry. I'll work with kids using different textured utensils if they have trouble tolerating different textures. But within these sessions, I always obviously have the challenging food, but I have a preferred food nearby that helps with their comfort level. It can be a motivator and a reinforcer to them, and it's less intimidating. Imagine if you had a bowl full of grasshoppers in front of you and someone asked you to eat it. That's what these kids kind of feel like. So what does a typical sensory feeding session entail? Like I mentioned before, I have kids participate in sensory activities to improve their attention, their regulation, their comfort level and stress levels before sitting at the table to eat. The feeding portion, I set up the table with a preferred and non-preferred, or might be a few non-preferreds and a preferred food that I've collaborated with the family on. And within that session, I'm making feeding non-threatening and fun for them. And for each kid, that's going to look a little different. Do we try some of our food challenges and then they get a break to swing or play a game? Are we doing more food play with them? I have some older boys on the autism spectrum that love having a challenge, selecting the order of the foods they're going to eat. We say, okay, how long is it going to take for us to eat the chicken nugget? Can they beat their time? Can we make it competitive and fun? As previously mentioned, we're looking at if these kids can self-feed as well, and that's going to enable their success within the session. So do they have good fine and oral motor control? Have they acquired most of their feeding skills? And if we push them too hard to self-feed, will their nutritional stats be compromised? So you might have to do a mix where they're self-feeding and you're also helping feed. That way they get all the nutrients and food that they do need. I have feeding milestones within the presentation. Just for time's sake, I'm going to skip those slides. That way I can give you all of the therapy information. Okay, something that both OT and speech both see within our sessions are behaviors such as food refusal. So we know that food refusal is going to impact nutrition and sustaining growth, but we have to take a step back and see what's leading to that. Is there some sort of medical condition, food allergies, that's going to impact that child's desire to want to eat and lead to negative mealtime behaviors? So what are some strategies that we can use? Again, we have to tease out what are those underlying concerns. Using play and sensory strategies to help reduce the child's stress, but also introduce food in a non-threatening way. One of the things mentioned on here is stretching a preferred to increase their acceptance of a non-preferred. So example, we have a little girl coming in and she has very limited diet. She has very specific chicken nuggets that she will eat. But her grandmother made homemade chicken nuggets, which looked and smelled delicious. But it produced a lot of anxiety for her to eat something that was a little bit different from what she had eaten before. However, it was the perfect opportunity to stretch preferred to a non-preferred, stretching the preferred brand to another presentation of that chicken nugget, for example. Having a preferred chip, but maybe trying it in a different flavor. Anything to expand these kids' diets. We'll often see kids who expulse their food, so they spit out the food to avoid eating it. What do we do in those cases? As much as possible, we try to ignore it, but then also redirect and show the child an appropriate way to discard that food. And the child learns in this process that spitting out their food doesn't lead to the end or the escape of a meal. And that's not always easy to do. All right. So I have another video, a 4-year-old girl working on feeding skills for you guys. Okay, so you guys can see in that video, the therapist was very successful in addressing that child wanting to spit out their food. She gave her that prompting to chew the food and try it. The child definitely had a challenge with it, but the therapist redirected her to an appropriate way of spitting out her food. But then what was great was because the therapist stayed positive, she didn't say anything like, don't spit out that food or that's bad. She just stayed positive and readdressed her. That child started to engage more and try more of the foods. And she responded well to that praise. She liked the high fives and the encouragement. So something to keep in mind as you face kids with feeding challenges. So I also want to point out community resources for everyone. In addition to services at TheraPlay, there are various feeding clinics throughout the area. They do a very comprehensive evaluation. So earlier on, I mentioned having that large team of professionals. Usually at these feeding clinics, you are going to have all those professionals together on site, and they're going to provide recommendations for you. This might be going to an intensive feeding program where you're there maybe all day, every day for a few weeks, a month, or they might refer you to someplace like us, like TheraPlay, doing outpatient feeding services. Another community resource that I want to draw your attention to are behavioral programs that address feeding. So these are kids that have strictly behavioral concerns. Oral motor issues have been ruled out. Sensory issues have been ruled out with maybe limited success with sensory strategies. And these are often run by or addressed by social workers, behavioral therapists, and psychologists. Some of the kids that I see too for feeding therapy that present with some behavioral issues in addition to the sensory, if they have a BSC or a TSS, they are more than welcome to come into that session. That way they can provide those strategies to the family and help them do it within that home setting and generalize it outside of their therapy session. Okay. So obviously early referral is imperative when it comes to feeding and really any issues that you might be seeing. If feeding issues aren't addressed early, concerns for failure to thrive, nutrition and growth might increase. You'll see more behaviors develop. And many of you know that stress and that guilt can become very overwhelming and really impact your family dynamic. And we don't want to see any drastic type treatment measures needed for these kids. We want to intervene early so they can be successful during mealtime. Okay. There's just some information about TheraPlay there for you and our different locations. Do a quick time check. I have a few minutes. If anyone, I have 5 minutes. If anyone has any questions.
Melissa, this is Carrie at Pick. I do have a question.
Sure.
I know TheraPlay is pediatric services. Is there an age where it's too late to try to address these issues with a young adult?
Okay, that's a really good question. So we see kids from birth to 21. Obviously, the younger they are, it can be a little bit easier to work on the issues because certain habits and certain issues haven't gone untreated for a long time. But with that being said, if we have some kids that are a little bit older or young adults that come in that are motivated, then feeding therapy can definitely be a viable option for them. I'm actually seeing a boy that is, I want to say 17, 18 years old, a little bit older teenager. And he's had feeding issues most of his life, picky eating, and he kind of decided, you know what, I don't want to do this anymore. I would like to try to eat some different foods. So we could definitely still see some of those young adults and tease out how we can best help them.
Wonderful. I have a 25-year-old who feeding therapy wasn't a thing when he was in, the early grades way back then. And he's a very, very difficult eater.
Gotcha. So with someone that's over 21, they can certainly call and see if there's a way that we can treat them. But I know our managers have to take that as a case-by-case basis.
Right. No, I understand that.
But yeah, oftentimes, other facilities meant for adults might not be equipped to work with young adults that have those sort of feeding issues. So it's definitely something worth calling and asking about.
Okay.
I do have a question on here. Can you show the slide with different ages, specifically 1-year-olds? Yes, I was able to get through a little faster than I thought. Good. All right, let me see 1 second here. I want to lose the meeting. So 10 to 12 months. So by a year old, a child should be eating mashed table foods with noticeable lumps. So that's really the age where more table foods can be introduced and they're going to start taking liquids from a cup. They're young, so you're not going to expect it to be completely smooth and refined. Oh, okay, one more slide, Bridget. All right, let me finish up with that in case anyone else wants to know about it. They're going to use tongue protrusion under the cup just to get some extra stability. And this is when you're going to start to see a more sustained and controlled bite, usually through something like a soft cookie. If they have teeth, then maybe a harder one. And then you wanted to see the next slide, Bridget. Bridget, was there anything specific on the next slide that you wanted me to talk about? All right, I'll just touch upon it a little bit. So between 13 months and 2 years old, you're going to see that the child progresses through their different feeding milestones. And by 2, they really should be able to manage any type of food, and they're really fine-tuning their skills at that point. Okay, you have a 1-year-old in your care that's difficult to feed. So at 13 months, they're going to start to playfully bite on a spoon and cup. You're going to see more of a controlled bite through that hard cookie, especially as they hopefully have some teeth at that point, and they're going to be doing more chopped table food. You want to think about, do they have good control of their tongue and lips? If feeding, obviously, if the oral motor part of feeding is difficult for them, then you might see food refusals because it's too much of a challenge. It might feel threatening for them. Did you have any other questions about that, Bridget? Or does anyone else have any questions?
I have a question.
Sure.
My son has more of a, I think, behavioral feeding issue, because we've seen a speech therapist and she kind of discharged him because he knows how to eat and he's swallowing right, he's chewing right. It's just he eats different with each person, and he eats the worst, I think, for me, his mom. And he only eats about 4 different things.
Okay.
Just like mac and cheese, chicken nuggets. It's not so much the manipulating and swallowing the food, it's the behavior.
Okay. Is there any concern at all with like textures, tastes, or smells?
No, I don't think so. I mean, he doesn't get freaked out over certain textures that I've noticed.
Is he okay with things like getting his hands messy when he's eating, or even just like playing, doing messy play, dirty at all?
I think he's fine with that with me.
Okay. And if he's sitting, maybe for something that's preferred, do you see any issues like now, again, he's young, but being able to kind of sit still to do that preferred play activity?
I'm not sure about that. I'm not sure how to answer that. I know when he's sitting in the chair, he tries to stand up a lot instead of sitting down. And when he's done, he's done. Like, there's really no persuading him to take another bite.
Yeah, I'm wondering if there's any kind of sensory component to it, but a lot of what you're telling me kind of indicates it's more of a behavior-based feeding issue. And obviously with food, that's one thing kids learn early on, that they can have a very big sense of control over. So with that, if he's really limiting his foods, that's obviously a concern, especially if it's 4 foods. You might want to collaborate with your therapist to see if there's any kind of behavior support that can be given in that regard. Without seeing your child specifically, it's hard for me to give specific strategies. Yeah, but that's something I would look into to see if that can give you any kind of help and to make some sort of plan for you.
Okay. And I just have one more short question.
I'll
he knows
I have to
go. He knows how to sign all done. So when he says all done, do I let him be all done because he's kind of asking me, or do I try to keep going if he's only eaten a tiny bit?
Yeah, so there's a fine balance between that. If you have a certain expectation with him for the food and he signs all done, I would want him to complete even just one time of doing whatever it is you want to do before you honor the all done. So say you want him to kiss a carrot and he says all done. You could try first kiss carrot, and then we can be all done. Or, oh, I know you want to be all done. Let's kiss the carrot, and then we can, whatever it is he wants to eat, he can have, or play with a certain toy. And then he's starting to learn that he has to meet that expectation. The thing is, all done is great that he's communicating that, but if you honor that and he learns that he can escape from a task, then that can kind of escalate into more behaviors. So again, it's kind of a fine balance, and that's something to work on with the therapist too, to really determine when do I honor that all done and when I don't.
Okay.
But I don't want him to learn that he can get out of your expectations all the time by saying all done. If that makes sense.
Yeah, definitely.
All right. Well, everyone, thank you for attending the presentation. I do have to move on with the rest of my afternoon, but I appreciate everyone coming and bearing with the technical difficulties.
And just so you all know, we will have a copy of the presentation in a video form. I'll mail you a link to that. All right. Thank you, everyone.
All right. Thank you, everyone.
Bye-bye.
Bye.
Bye.